Thank you for joining us. We're interviewing today. I'm Dr. Sherry DeSchaff. I'm the owner of She Fit Physical Therapy in San Diego. We are a women's health, pelvic floor, prenatal, postpartum specialized clinic. And so we care a lot about the pelvic floors and perineums of birthing women and people. And so Sarah is a midwife, a licensed midwife, and a doula monitrice, and she is co-owner of Night and Day San Diego, which offers a variety of services. I'll let her tell you kind of the big hitters that they offer. And we are going to talk today about her perspective as a midwife and doula on how to protect your pelvic floor and how to optimize your recovery post-birth. So, yeah, welcome, Sarah.
Thanks.
Good to have you. So why don't you tell us just a second, your practice, the services that you guys offer.
So we offer everything from birth to postpartum. I am a monitrice, so I focus on birth doula care. My twin sister is co-owner, and she's a lactation consultant. She's an IBCLC, and she also has Emma helping her, another lactation consultant. So we do lactation care. We have a registered nurse offering postpartum doula services. So birth, belly binding, lactation support, postpartum care is kind of all within our group.
Cool. The whole spectrum.
Yeah.
Awesome. And you guys do breastfeeding support groups too, yeah?
We haven't in a little while, but we're hoping.
Okay.
You know, we'll watch COVID.
We'll talk about that later.
Yeah. We miss it. We really miss it.
Yeah. All right, so let's jump into some questions. So I know you're both a midwife and a doula, though you're not currently offering midwife services. You've done home birth midwifery for quite some time, and then currently you're offering more doula services. How would you explain the unique role of a birth doula compared to a midwife or a partner or a support person?
Yeah, so I'll start with what a doula does. So, and kind of compare it to a midwife, and then I'll talk about this confusing thing that I add in there of being a monitrice. So, it's like if it wasn't confusing enough for people. So a doula is traditionally a non-medical support person whose primary goal is to help families have a positive birth experience. So whether that's position changes, back rubs, reminders to eat and drink, spinning babies positions, whatever we can do to help the birth progress smoothly and for the parents to feel good during the process. And then a midwife is a trained medical professional. So their goal is to help healthy, low-risk women to have low interventive births, and they can do all of the medical aspects of things. So the prenatal visits, intrapartum care during the birth, and postpartum care as well. So just like an OB delivers babies, midwives also, catch babies. And so doula is there in the non-medical role, and midwife is there as part of the medical team. And then you have a monitrice, which is someone who's trained in both. And I'm really focusing on the doula aspect of things, but I can also, while women are laboring at home, check baby's heartbeat, make sure they're doing well, check mom's vitals, and also do cervical exams. So we can really time out when we're going to the hospital. And I can also bring in this knowledge of being a home birth midwife and working at birth centers, bring that like holistic side of things to families who are birthing in the hospital. So they can kind of, we're trying to get the best of both worlds, I guess.
Yeah, and that's interesting because I was wondering if there were, licensure things between being a midwife and being a doula and what you can and can't do when you're technically someone's doula versus their midwife. So that's interesting to know that the monitrice kind of bridges that gap.
Right.
Where you can add some of those midwife type interventions or checks or assessments when the woman is still at home and help decide when to go, like when's appropriate to go.
Right.
Yeah.
Yeah.
That's
and
very
it gives
cool.
some reassurance that like baby's actually doing well.
Yeah.
Doulas are really good, even if they don't have medical training and don't do cervical exams, at like kind of seeing where people are at in labor and helping them decide to go. But sometimes you just want that number.
Yeah.
Like what's happening with your cervix. And every once in a while we're surprised. So it's handy.
Okay. And then how about between, because I know a lot of times, especially first time for first labor, right, when people haven't been through labor before, thinking, well, my partner's really supportive, my mom's going to be around, or my sister's going to be there and she's had 4 kids. Like, what would be the difference between a support person like that and having an actual birth doula?
Someone who could be objective. There's a difference, but of course we build rapport with our clients as doulas throughout the pregnancy, and we get to know each other. You have that bond, but it's not the same as seeing like a loved one go through labor and be uncomfortable and those sort of things. So you can take a step back and be a little bit more level-headed than maybe your family members can. So they bring this love and relationship, and we bring this experience and expertise. And most of the time, and unless you have a family member who's had a few births, most people haven't supported anyone else in labor.
Yeah.
Or maybe even ever been to a birth before. It might be everyone's first time in the experience.
Yeah.
So having someone who can kind of be a trail guide can be so helpful in just making everyone feel more relaxed and more supported, and to help you know your options.
Mm-hmm. And I know for me, my first birth, I've had 3, all vaginal, unmedicated. My husband has been an amazing support person, which I didn't necessarily expect, but he's been amazing. With the first one, my labor was really, really long, and he reasonably would probably just get tired, right?
Yeah.
Over 36 hours of having to support me, much of that being at home, and then some of it at the hospital. But even at the hospital, there's not always someone in the room helping you, you know. So just to have some relief for him from massaging me and coaching me and dealing with my demands as a laboring person.
It's not necessarily a one-person job.
Yeah.
It's not. It's a lot of work. And I always tell people, because sometimes partners feel bad about like taking breaks. So I will encourage partners or family members to like lay down for a little bit. I'll take care of it. And we'll take turns, and we'll make sure that everyone's rested and has eaten something, because even though mom can't take a break and we kind of feel bad about that, she needs people who are fresh around her to encourage her. If everyone feels like falling over at the end, then we're not doing anyone any good. So, laboring woman needs fresh people, and that takes a team.
Yeah, for sure. All right, I'm gonna jump to my next question, even though could go more on that one. So I advise my patients as a pelvic PT a lot on breathing, pushing strategies. How do you optimize these neuromuscular and musculoskeletal relationships in the labor process, as well as pushing positions for protecting the perineum and the pelvic floor. I advise on that based on a pelvic floor PT perspective, but I'm curious, from the midwife perspective, what positions do you find that mamas gravitate toward, especially in the pushing phase? And then how often is it the position that they planned on versus one that they didn't plan on? And then on top of that, is it the position that always feels the best? Is that where they should be? Or do you sometimes recommend other positions for different reasons, that they maybe get out of the position that they're thinking that they want to be in or planned on for other, medical reasons, or to protect the perineum than what their body is necessarily telling them?
It can be kind of hard to know what position you're going to want to be in. I think a lot of people, especially if you're considering an unmedicated birth, think of themselves or envision being in a squatting position to give birth, and that's totally doable. You can even there's squat bars, and you can use those in the hospital in the bed. But I find most often, at least first-time moms are sort of fatigued by the end, and we're often encouraging them to kind of move around and get into different positions when they kind of just want to lay down. So I find side laying and hands and knees are probably the 2 most common positions that women just naturally gravitate towards.
Okay.
As a midwife, I'm seeing deliveries in all different positions: standing, in the shower, on the toilet, wherever. But especially in the hospital system, we talk about how can we navigate what is customary for the staff there versus kind of what's ideal for the pelvic floor, and how can we communicate and create a scenario where we have some flexibility in what we're doing, what position mom is in. Yeah.
And I know you're working a lot right now in the hospitals.
Yeah, primarily.
So what would you advise for people who are using an obstetric provider in a hospital leading up to the labor? How should they be prepping their obstetrician to see what positions are going to be an option for them?
Yeah.
Compared to, I know you and I both know the evidence suggests that side lying is, whether epidural or no epidural, side lying is the preferred position, but it's so rare, I think, for people to actually birth in that position, especially in the hospital.
Yeah.
I don't know, I've only seen my own births.
It's becoming pretty common. A lot of the deliveries that I attend, I do encourage them to get in side lying, and it's actually, it's doable with an epidural or without an epidural, and it's in the bed, so it's also sort of this middle ground of an OB might feel uncomfortable delivering a baby outside of the bed, standing up, but feels very comfortable just, keeping the bed together and catching a baby in a side laying position. It's not that different.
Okay.
And, so side laying is really an easy position, I would say, to a happy middle ground. Yeah.
Okay.
So one of the first things is to find out what's standard in your place of birth. And do you have options to go into a setting where they're more flexible places that have midwives. Midwives tend to be really open to being in different positions for pushing. So that's, I think, step one is try to set yourself up so that you're in a setting that's more flexible. Step two is to communicate with your provider, find out, what's common in their practice or their group, and then creating a birth plan, but then also learning how to communicate that. And the nurse in the room can be such an advocate for you too. So the OB comes in closer to delivery, but if we have a nurse who already knows the plan and can help us communicate that I find is really helpful. So yeah, expectation management is part of it. Just know what's common, how your provider feels safe catching babies, and then, find ways that we can communicate what we're hoping for and, just work with the circumstances that we have.
Yeah. And that communication piece, I think, in the hospital, in the labor, is one of the benefits of having a birth doula.
It really is. Yeah, because no matter what your ideals are going into the birth, when you have worked all this time in labor and then you get to the point where you're getting closer to meeting your baby, you become a little bit more, if you're tired and you just want your baby to be born. So you're like, what do you want me to do? Like, be on my back in stirrups, like you just don't care at that moment. Yeah. So having someone to kind of remind you of your preferences or to help you to communicate that can be really helpful. Yeah. And there's a time and place for everything. So, not to say that being on your back is never the thing that works. But yeah.
What about that? Two questions left. We're going to squeeze them in here.
Okay.
So what about that last part of it? Is there ever a time where you recommend they get into a different position than what they're feeling like they prefer? And it's interesting because my third one, I was sitting on the edge of the bed and using a lot of sitting and squatting to get through my transition. And then the midwife was going off shift and she said, when you're done with this one thing that they're doing, try getting up on hands and knees on the bed over the birth ball. She's like, I think that'd be a really nice position for you right now. Yeah. And I was like, okay. And then I finished, doing whatever they were doing. And my husband reminded me like, hey, the midwife said, let's do this. Yeah. And she was gone at that point, and he said, let's do this. And so as soon as I got in that position, it was like, we are pushing like now. We're not waiting for anyone. We are pushing now. Right. Awesome. So, I'm just curious,
that happens pretty often. In labor and in pushing, sometimes you need encouragement to just switch positions. So when we listen to mom's instincts, and if you feel really comfortable in one position and it's working, then we're not going to change anything. Like, let's just stay there. But if you can see that maybe some more progress would be made in a different position, then I'll encourage like whatever we're doing to like switch it up. And we sometimes do a rotisserie chicken sort of thing, especially if mom has medication. Just like let's switch the diameters of the pelvis by moving from one side to the other side, being on our back, just like, and we can even sometimes get into hands and knees with an epidural, especially with unmedicated. We're going to try a variety of things, see what works best. And I think sometimes once you've tried a few things, you will find a spot that all of a sudden you see all that hard work pay off. Yeah. So sometimes I don't even think it's like the ultimate, like, or the last position. It's just like all of this work accumulating of you working in different positions and rotating the baby out.
And you and I had talked before, you are in some ways limited, but that's another time where I think if you have an epidural, potentially hospital staff is going to be less prone to switch you around, move you around, because when someone has an epidural, they're not usually maybe used to doing that, versus your doula is there to say, hey, we've got the epidural, but you still have full function of your legs. Let's go ahead and, change positions and do something else. Yeah. Even with that on board. So.
Yeah, it's really nice. A lot of the nurses are being trained in spinning babies, and
so
we're seeing a lot more of, nurses saying like, hey, you've been on the side for like a half hour. So like multiple people in your room encouraging you to move around.
Yes. All right. Last question. Okay. So I know you have helped a lot of mamas have low intervention hospital births, which is what we've been talking about. Can you give our listeners some advice on how to avoid coached pushing? So we know as birth providers that the evidence suggests that coached pushing is not the best, but uncoached pushing demonstrates lower incidence of perineal tearing. Yeah. So tell us, how do you manage that?
The most evidence-based way we can prevent tearing is by not coaching women, and we know that. Like we have all these other ideas like warm compresses and all these things. It's like ultimately it comes down to mostly letting mom do her thing, but avoiding pain medication can definitely help, because if you can feel what your body's doing, you're going to be better able to work with it and just listen to the cues of when you need to push, how much you need to push. So that's huge.
Cues from your body.
Yeah.
Right. You're talking about versus from a
Exactly.
doctor or nurse.
Exactly. Yeah. So thank you. And then practicing before with the pelvic floor PT. When we were talking beforehand, I was like, this is really great. The idea of practicing what you would need to do beforehand so that you can make a mind-body connection if you can't feel exactly what's happening. So I think that's really, let's just start sending them your way beforehand.
Yeah. Well, yeah. So we were talking about, as a pelvic PT, I like to, we practice contract and relax. Can you lengthen and then can you push? Like we'll do some practice pushing. Can you coordinate that abs and pelvic floor lengthening and then not just on your back, but can you do it on your side? Can you do it in hands and knees? Can you do it in all these positions that your doula or your midwife might ask you to get into when you're actually, laboring and pushing? Because we support each other in the way we're training and preparing people to get the best and the most that they can out of their birth experience.
Yeah.
So top piece of advice you have for tear prevention?
Oh, top piece.
Number one, if you could only have 30 seconds to tell people how to prevent a tear.
A supportive provider, hiring a midwife. That way, all of these other pieces fall into place a lot more easily. If you have a provider who has a low intervention rate, you're going to be more likely to have an intact or, mostly intact perineum. So choose your provider really wisely and carefully and make sure that that your philosophy aligns with theirs and that everyone's on the same page.
Yeah. Great. Well, thank you so much for your time. I think we packed a lot into 15 minutes. This is great. So again, if you guys have questions and you want to comment below, Sarah and I will both kind of look at the comments over the next few days and try to answer any questions that we see pop up. You can find Sarah and her practice at www.nightandaysandiego.com, right? And get more info on her. She's a Facebook page and Instagram account as well. You know where to find me because you're here. And then we are going to be doing some interviews with colleagues of Sarah's, particularly her lactation consultant, Rachel, right? In a few weeks. So stay tuned for that and have an amazing Thursday.
Yeah.